Have you stopped to consider the profound impact that medication can have on our well-being as we age? Over 1/3 of older adults are taking 5 or more medications, and at least one of them may be completely unnecessary. The result? Approximately 2 million adverse drug events requiring hospitalization every year. Dr. Donna Bartlett, a board-certified geriatric pharmacist with over 17 years of clinical experience and 20 years in the retail pharmacy sector, has made it her life's mission to tackle this issue. My guest today is Donna Bartlett, the author of MedStrong, Shed Your Meds for a Better, Healthier You, Aging Well Through Deprescribing. She is also a professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Services University. In addition, she is the co-host of a podcast called The Med List. Her extensive expertise spans a multitude of critical areas, including polypharmacy, medication access, and fall prevention. Dr. Bartlett's passion for optimizing medication regimens known as deprescribing. Today we talk about the essential reasons why deprescribing is vital for both the older adults and their caregivers, the complex factors contributing to medication overprescription, the practical ways we can become advocates for appropriate medication management, and we'll discover the medication optimization plan and learn how we can ask important questions and work effectively with our healthcare providers. This conversation will give us a glimpse into medication management and empower you to make informed healthcare decisions. Here is my interview with Dr. Donna Bartlett. Hi, Donna. We were just saying how excited we were. We finally get to dive in, talk, have a conversation.
Absolutely. Thank you so much, Nicole.
Yeah.
So glad to be speaking with you.
Thank you for being here with me.
Absolutely. Thank you for having me.
Yes. Thank you. Oh, I'm looking forward to this. Well, I'm holding up your book. I read this. For a topic and a conversation, I think that maybe is not mainstream or that what's the word? Sounds like exciting, right? To
Right.
us, it is because it's our passion in supporting older adults and families. But I thought it was digestible. Reading through it was clear. I understood. I loved the charts and the graphics you used. We'll get into a lot more of the details, but to set us up, can you tell us, how did you get to this place of wanting to write this book? A little bit about your background and your heart for supporting older adults and their families.
Absolutely. So my background is I'm a pharmacist, and I've been a pharmacist for 27 years. And through my journey of pharmacy, that's both retail and outreach programs and academia. And now I also have a hospital site. There's a lot of folks I've seen throughout my 27 years and have counseled, and many have been older adults. And when I was getting my doctorate of pharmacy, so first I had a bachelor's of pharmacy and then eventually went back to school and got my doctorate of pharmacy. At that time, I decided to become concentrated in geriatrics too. So soon after I received my doctorate, I became board certified in geriatric pharmacy. So that's where that blossomed out of, if you will. At that point, though, I knew that I saw the road of the baby boomers moving forward and going, you know what, we really need to be specialized in this area. So I did move that forward. And why did I write the book? Well, one, I wanted a sabbatical, I will admit.
Yeah.
And I was really trying to come up with what I could do. And I've always counseled people for so many years. And when I was really thinking about a project that I really wanted, it hit me like a bolt of lightning one day. And I just started writing feverishly and went, this is it. This is what I'm passionate about. This is what I want to do. And writing down a lot of the information I've learned that I want to and have shared with older adults and caregivers and providers throughout the years. So that's how this all came about. and just very passionate about reducing unnecessary and inappropriate meds in our older adults.
That's when you know it's inspired, when you just the writing, right, when it kind of takes over, that is all pointing us in the direction of, okay, this is what we're meant to be doing at this moment.
It's been exciting to do it too, and I love that you think it is digestible because that's what I wanted it to be, is
Mm.
digestible.
Good. It really is. It really is. And we often hear about the dangers of over medication, the different things that can happen. Specifically with our older adults, there are often times where if we're not a medical professional, we don't really know what some of those signs and symptoms may be, that it could be possibly a medication related issue. So, can you shed a little light on that for us as we're starting this conversation in terms of what is even over medication? What is deprescribing? We'll get into that.
Yeah.
But set us up for what are we looking for? Why is this an issue?
So with over medication, people are a little bit surprised when I might be presenting or asking them individually, oh, you take more than 5 meds. And then people are a little surprised about that. Over 40% of our older adults take 5 or more medications.
Wow.
The reason why I'm targeting 5 is because that's what we see in literature for polypharmacy. And that just means multiple meds. And the more meds we take, the more likely there is for side effects and issues to ensue. The number doesn't really matter to me. What matters to me is the medication appropriate? Is it needed? Is it helping you? Are you optimizing it to the point where it is you're taking this particular med and you need it right here and now? And it's an
Right.
important part of being healthy and feeling good. The whole over medication side of things is we think, oh, I've been taking that, it's helped me, I better continue to take it, where that might not be the case. And I think, unfortunately, many older adults now, if you think back 20, 30 years, maybe even longer, that they've been on some meds for, they were probably told you're going to need this for the rest of your life,
Mhm.
but we're living longer. These meds weren't necessarily intended to be 30 plus years of
Right.
use. Because things change, we might not need all of these meds all the time. So often, just to answer the other question that you have, is how do we look at this? How do we know if we're having a side effect or not? And that's one thing that I do say to patients and to providers too. Providers, if you go to the doctors or something, you'll often be asked, so do you have any side effects? And who knows that if you're not in the medical side of things?
Yeah. You
Oh,
wouldn't
I
even
know
maybe
there's
know what
side
one
effects
is.
to this.
Yeah.
But instead, I like to take a different approach to this. And I ask patients, what over the counters are you grabbing? Or
Mm.
what are you trying to do with that supplement? And what are you hoping to glean from it? And there's got to be some value for you to go to that pharmacy or store or online to figure out, okay, I need this medicine, or I need this supplement, or I need this OTC. It's for some reason. And that reason could be a side effect to
Mm.
medications you're taking. So sometimes folks themselves are adding on meds, supplements over the counters, and they are overprescribing themselves versus just the providers that might be saying, oh, you have this new problem, let's treat it, when it could be a side effect.
That is aha moment for me because I had never really thought about the different things that we treat as a result of the medication we're taking. But what an insightful question to ask someone to maybe narrow down, is this a side effect of the medication we're on? Yeah.
I had somebody ask me one time, so I take a lot of vitamin C. Is that okay? And I said, yeah, vitamin C is okay as long as it's not causing a lot of acid reflux for you. And then you're taking something for acid reflux.
Mm.
And this person said to me, oh, we got to talk.
Oh,
So, like people,
interesting.
because vitamin C is an acid, and if you're putting more acid in your stomach, you could be causing an acid issue. So that GERD that people love to
Yeah.
talk about, or acid reflux. So people might think that they're helping themselves, but they
Right.
might be undoing something else.
Totally.
So it's always good to check these things out and have these conversations. And it's amazing what is in conversations with patients and caregivers, what we come up with when we're looking, really digging into someone's medicines and
Yeah.
why they're taking them.
Right, it's that being curious, right? And just asking questions and diving deeper. So, okay, that was super interesting about the vitamin C. What are some what are some other examples of, I just think that that's so interesting, of maybe things that are commonly that we take but that are leading us to maybe have to treat something else.
So one of the things, just talking about this stomach acid, so
Hmm.
a lot of people, whether they take vitamin C or not, they might complain of stomach acid or acid reflux. So they take a medication called a proton pump inhibitor. For example, omeprazole or pantoprazole are a
Mm,
couple of those meds that are used and pretty popular. Those are only really supposed to be taken for 8 to 12 weeks time, but
wow.
people are on them for years. And after a year of being on these proton pump inhibitor, acid reducing medicines, we're actually reducing absorption of a lot of wonderful
Mm,
nutrients that we have available to us in our food, and that we should be intaking to keep us healthy. So one thing in particular is magnesium that doesn't get absorbed very well if we don't have enough acid in our stomach. And so people will complain of leg cramps, for example, and then they'll find out from a friend or the pharmacist or someone somehow that, oh, magnesium is really good for leg cramps. So they start taking magnesium, not realizing that they've been inhibiting the absorption of magnesium for over a year with
wow.
that proton pump inhibitor. And now they have a deficiency, which is now causing leg cramps. The other thing magnesium can do, because your heart is a muscle,
Hmm.
it can, in low magnesium can increase the risk of arrhythmias as well. So we got to be careful of these medicines and thinking like, oh, it's over the counter, I can just take this. We really got to be thinking about how long, for what, and is it appropriate. I know that writing's really small on those packages over the
Yeah.
counter, but you have to pay attention to them. They're there for a reason. Grab a magnifying glass if you need to, or ask a friend to read it.
Right.
It's really important that we look at these critically and what we're doing. So in that case, you would ask somebody, or I would ask somebody at a med review, oh, you're taking magnesium. Tell me, why are you taking that? And if they say
Hmm.
leg cramps and I see that they're on these proton pump inhibitors, then I know, like, okay, it's been over a year since you've been taking this, probably.
Right, right.
So that's part of it. Other meds, there are things that people with type 2 diabetes, for example, they might have been on or still on metformin for a number of years, which is a very appropriate drug for type 2 diabetes. But over time, it can reduce B12, our
Mm,
vitamin B12, and vitamin B12 deficiency mimics the similar symptoms of diabetic neuropathy. So people get a burning or tingling in their hands and feet, for example, and it's called peripheral neuropathy. It's very uncomfortable. So then
mhm.
they'll end up taking something like gabapentin for that, which is used for diabetic neuropathy as an off label medication use. But it really could be that their B12 is deficient, but a lab test isn't being done to check that. So they're just going on to the next med
Right.
without really seeing whether or not the B12 is really deficient from being on metformin for so many years.
Yeah, kind of dialing that in. Are there certain physical, what's the word I'm looking for, signs or symptoms that are present that could kind of do that moment of maybe this is an over medication or like a drug interaction, or does it really vary depending on the medication?
Yeah. So it can definitely vary, and it depends. Like some things you notice pretty much right away.
Hmm.
Um, so say for example, you're taking ibuprofen for something, you're taking it for pain. Maybe you hurt yourself exercising or something, or you threw your back out, and someone's taking ibuprofen around the clock. So, 3 times a day um, as it's directed, and it's been like 7 days now. And
Mm,
then now they're starting to get swollen ankles or edema in their legs. It could be the ibuprofen that's doing that. Because ibuprofen can retain fluids, and depending upon other meds that you're taking, it might be causing issues of your in reducing your kidney function. So we have to be super careful of what people are choosing over the counter in
right.
that regard. And within 7 days, we might start seeing some of those side effects. Other things, people might just get, ill from it, and not feel
Mm-hmm.
right, lightheaded,
Mm-hmm.
dizzy, different things like that. But some things, like some of these deficiencies that we might see over time, people don't think like, oh, I'm not feeling so well, or they love to blame things on age instead.
Mm.
So a lot of people take statins for their cholesterol, for example, and very high dose statins can sometimes cause aches and pains in your muscles, and over time it could actually cause some weakness, because if you're achy, you're not going to exercise as much or move as much.
Right.
So therefore, now we get into, okay, I feel weaker now. And people love to blame that on age, when really they weren't realizing that over time, the statin might have caused some discomfort
Mm-hmm.
and eventually had that effect on them to not move as much.
Right. So, what are those factors that lead to that over medication? Is it our pharma culture? Is it that, right, we chalk things up to age sometimes, of this is the time of life where we might have some more ailments? What are you finding are those, yeah, contributing factors to that?
Yeah, so I definitely think it's a culture for sure.
Mm-hmm.
I think over time, and we hear this too, many people hear, oh, you have to take this for life, like we had talked about. And
Yeah.
then there's this culture of, I don't feel well, I need something to make me feel better.
Right. Right away.
There's that doctor side of things that, oh, my patient doesn't feel well, I want them to feel better.
Mm-hmm.
So that's an issue too, where
Mm-hmm.
maybe it's a doctor that hasn't prescribed all of these medicines that someone's taking, because we see so many people now that
Mm-hmm.
can prescribe. So maybe they're looking at it as, oh, here's an issue and it needs to be treated. So that could be the reason. And then the other side of things too, Nicole, is there's an issue with who's responsible for stopping a med and then leading on that information to the pharmacy. So many people have automated refills.
Mm.
Who's stopping the automated refill?
Right.
There's not a clear system in order to do that.
Mm.
Sometimes insurance companies are saying, nope, you got to try this first before we'll give you this. And there could be confusion if those transitions are happening and the person doesn't realize, who's taking the med, that they need to stop that because that wasn't really working well. And now you're allowed to take this other med. So maybe the transitions of care too, going from one place of care to another,
Mm-hmm.
hospital back to home. What did they give you at the hospital versus what do you take at home? And are you confused at that point? People move in these transitions, and it tends to be a time of confusion
Right.
and unsteadiness and other things that can be an issue for folks.
Yes, and you talk about aging well through deprescribing. So, what does that mean?
Yeah.
And why is it essential for us to do that?
Yeah. So there are so many things that, again, we love to blame on age. And it might be, I'm tired,
Mm-hmm.
I'm weak, I have constipation, my eyes are dry, I can't keep, they bother me. There's just so many issues that we have. And there's a lot of additive effects of medications for folks that they might not realize, that they might be okay on this one, but they now have like 3 or 4 meds since that time for various issues and side effects. So things keep adding on and adding on and adding on. And with that, their lists grow, and then they start to not feel well. And we talked
Mm-hmm.
about some of those examples before. And then they're not aging well. They're not out and about. They get confused. They fall. There's a lot of issues around a couple of factors. One is called this anticholinergic burden, and it's
Mm.
a grouping of side effects that cause dry mouth, dry eyes, constipation, dizziness, cognition issues. It's the stuff in the PM pain relievers, as one example, or things that people use for urinary incontinence that causes this type of side effect. With that, falls increase as well. People feel like they're hungover from it,
Mm.
so they're not doing well the next day if they're taking a dose of
Right.
PM either. How are you aging? Are you aging with all this over medication and not feeling great and always going to the doctors? Or are you aging well, taking only what you need so that you're able to still stay in your community, communicate with others, socialize? I was just talking to some colleagues last night about, we are talking about loneliness, right?
Mm,
People don't necessarily realize that their meds could be causing their loneliness because they're unsure of themselves. They're dizzy. They don't want to go out. They're becoming forgetful. They don't want to be embarrassed or various things like that. Maybe they do feel unsteady. So they're not engaging as much because they don't want to use the walker or the cane in front of people, whatever it might be.
mm-hmm.
But these are all things that could be caused by meds that people are actually isolating themselves
Right.
and then therefore not aging well either. So there's so many different factors, and we know that moving, nutrition, socializing, all these things are really important to age well. And if our meds aren't compatible with us, then we are cutting ourselves short of being
Right.
able to age well.
Oh my gosh, so true. And I love one of the tables or charts that you had created in the book where it talked about the different medications that contributed to different age related conditions, such as like falls, overactive bladders, what medications would potentially lead to that. And I thought it was such a great picture to see, okay, if I'm maybe experiencing some of these things that are causing that isolation or loneliness, maybe here's some things I can look at and kind of like give us a place to start.
Exactly.
Yeah.
Exactly. And of course, the list is not exhaustive, but
Mm-hmm.
it makes you start thinking about that, and you can just start even asking those questions. I just haven't felt comfortable. I'm uneasy, or I don't want to fall because I fell once before. Fear of falling is a big
Mm-hmm.
issue. There's a lot of things, and but being able to exercise and getting stronger, taking balance class, for example, doing balance exercises, those are all things that can help you in
Yeah.
order to still remain engaged.
So, is deprescribing where the pharmacist or would our physician work with us on evaluating? You talk about that medication review. Is that a piece of that deprescribing process? Walk us through what's the best practice for that? Like, how do we do that or get started or question that piece
So
of
there's a lot to this
it?
question. And I
Mm-hmm.
think one of the things in the book, Nicole, is the 5-step medication optimization plan process. And that really will help guide people through that. I actually have a workbook coming out that really allows for more of that information to be
Mm,
worked at. So that is coming out soon. But in the meantime, the book does take you through this 5-step process. What's important to have people understand, and I hear this all the time from folks, is, oh, I don't need you to check my meds for me. My doctor checks them all the time. Or, oh, I go to the doctors, they check it for me. And I go, okay, but I think people are thinking about when the medical assistant is taking their vitals and checking them in, and they sit with them and say, oh, are you taking all of these medicines? That's not a medication review. That's a med rec. That's just getting your record of what you're taking compared to what is available in the chart.
right.
And so that's very different than a med review. A med review takes time. I allow up to an hour for my first consultation with my patients that I am actually doing medication reviews for. That is after the hour I've spent reviewing all of their meds and looking at issues with interactions and, questions I want to ask the
Right.
patient to prepare myself for this 1 hour conversation. So it definitely takes time, and we need to be thinking about not only past medical history, why you're taking things. Is there still a need? Do you still have that issue? Folks, I just talked to somebody last night on a conversation that I was having, and they said, "Gosh, I wish I'd met you 10 years ago."
Mm,
They said, my mom hadn't been doing well, and when I brought her to the doctor later on, it was close to, she only really had a few months left. This doctor said, "Do you see all the meds she's on? She's on like 30 different medicines." And he says, "Why is she still taking some of these?" And one was some anti-seizure meds. And she hadn't had a seizure for 20 plus years, and she was still on anti-seizure meds. Anti-seizure meds, depending upon the person, if you're seizure free for 4 years, you can start talking to your doctor about reducing those. There's a lot of side effects to anti-seizure meds too. So, that's something to be thinking about. Maybe somebody had a life crisis where they were depressed and really had a difficult time, needed to be medicated, and maybe life has changed over the last 5, 10 years. Perhaps that antidepressant might not be necessary. I'm not saying, it's up to, the person just to stop taking a medicine. They should really be having these conversations with their doctors, and a lot of meds need to be reduced slowly over time. So kind of back to your question, who does the med review? I'm a proponent of a pharmacist doing a med review.
Right. Yeah.
Just because we're looking at everything. We're looking at all the meds. We're looking at the specialist meds. We're looking at, whoever wrote the med. We're not the writers of the prescriptions necessarily. So I think we're taking a very objective view and saying, oh, I can't touch that, or, oh, look at who wrote this one kind of thing. I don't think we're doing that. So anyways, I think it's important to get that perspective of pharmacist who specializes in deprescribing. And then what happens after that is, after we go through that process, you then have the questions to ask, and you have the ideas to have a really good conversation with your prescribers as to, do I really need this? I heard that this could maybe increase my risk of falls. I've been proactive all these years. I don't really want to have a high risk of that. Is it possible I can lower my dose, or could we switch it to a safer med if I do need therapy? So there are all these questions that we can prepare the patient to have the conversation with their providers. Also, Nicole, I think it's really important to stress that it's not a one and done conversation. It is literally every single time you're encountering somebody in healthcare, whether it be the pharmacist or the doctor, whoever's prescribing. Can I continue this? Should I continue this? Could it be deprescribed?
Right. Oh my goodness. Okay, so I had a couple thoughts as you were talking about. It just really, I think, highlights the need for, you have your specialty with the geriatric pharmacy and the importance of that. So one question is, age really does change the conversation when we're talking about medication, right? That impacts that. So that is one question. And then we'll come back to that. The other thought I had is, I remember talking to another pharmacist friend of ours, Donna, Canterbury, and I really did not realize how much schooling our primary care physicians had around pharmacology versus obviously our pharmacists, right? And then specifically geriatric pharmacy. So the importance for people to really seek and pursue that expert consultation when we know only 6 weeks in pharmacology for primary care, I believe was somewhere.
It's a small period
very
of time.
small amount. So a lot of us are relying on that advice from that one lens rather than let's really use our pharmacist as that expert for us as we're talking about. These are major, major issues that can affect our whole life, right? So seeking that expert out. Unfortunately, right, we need more of you in that geriatric specialty. So we know that your knowledge is very sought after. So I guess my question for you is some insights or thoughts about that, seeking that out, and also, just how the importance of seeking out that geriatric consult as well.
Yeah. So when we're talking about deprescribing and talking about age, yes, I did concentrate more on older adults. However, many folks are overprescribed no matter their age.
Right.
And that's unfortunate. So I have actually done med reviews for much younger people, people in their mid-20s even, who have been over-medicated and having issues. So really anyone can be over-medicated. There are pediatric pharmacists too that actually they concentrate on deprescribing in pediatrics as well. So anyone can be over-medicated. You could be on a medicine that is inappropriate for you. But what happens when we age, and I like to think about this when going back to that pediatric side, if somebody is treating pediatrics, a newborn to say a 20-year-old is probably your pediatrics time frame that you're seeing a pediatrician. You're not going to give the same medicine to a 1-year-old as you would an 18 or 20-year-old. That dose is going to be very different. Even the med could be very different. So now let's fast forward, and we have somebody who's 65. Maybe they've been on meds for a little bit of time already. Maybe they're starting on some new meds because of some changes. And now let's fast forward to 85, even 95, and folks are still on the same meds. That's 20 and 30 years difference.
Yeah.
That's no different than the 20 years. It's just more visible from a child to a 20-year-old. But that 20 years of 65 to 85, 95, our bodies are still changing. And one of the things that I like to bring up to folks is there's equations that we use to check on kidney function for people. One of the components of that equation is age. And as we increase our age, our kidney function actually reduces. And it's just part of the factors that impact that. So there are some things that do happen with age, but our bodies are definitely changing. So things like absorption changes, our stomachs aren't maybe have the same mobility, if you will, or absorption areas. So that might be a little bit different. There's distribution. Our drugs actually distribute to muscles and fat and the fluids in our system. They depend upon the drug itself. So that changes as we age too. We tend to have more fat as we age, less hydration as we age. So that is an issue. And we might need to adjust medicines for that reason. There's also this metabolism. So when we take a med, eventually it needs to be changed to a medicine that we can eliminate or a product that we can eliminate. And that happens in the liver. So our liver changes. Our liver gets smaller as we age and might not work quite as well. So, or we might be taking so many meds that it's competing for that space to be metabolized. So that's an issue. And then elimination, I already said about the kidney function, that can change. So lots of changes are happening in our bodies as we age. And it is part of the aging process, but we can adjust the medicines in order to complement that aging. Doesn't mean that, oh, I've been on that for 20, 30 years. It can't be that med. I've been taking it forever. I hear that all the time. But no, it can be that med because you've been taking it forever.
How many years?
So we have to like kind of weigh these things. The whole risk versus benefit thing is it changes, and things could have helped us a lot so many years ago, and now we may not need it so much, and now we're having more risk with that. So that's an issue. Sometimes people get healthier. People retire, they're working more. I mean, they're walking more, they're enjoying life more. They're not sitting in a car or sitting in an office, and they're not going through drive-throughs as much. They have time to cook. So those are really positive changes that happen too. So it's not always doom and gloom. It's actually, people are getting better and more fit and healthier too. So we have to be making adjustments for that.
Right.
When we're looking at like the experts and, the pharmacists pharmacists can help. I know that there are so many pharmacists that are so busy in the retail world right now, but I mean, you could ask your local pharmacist if for medication review, but I wouldn't ask for it on the spot. I would say, is there a chance that somebody could review my meds for me, one of the pharmacists, and when might I be able to come back and chat some more about that? There are also some medication therapy management availability. Depends upon whether or not somebody is within the parameters or eligible for the medication therapy management review through insurances. So that might be something that you could maybe work with. But for board certified geriatric pharmacists, there is actually a website through ASCP, the American Society of Consultant Pharmacists, that has a list of or a directory of senior care pharmacists or consultant pharmacists that are in every state of the United States. And you could actually contact one of them. So that's helpwithmymeds.org that you could be looking at. They're also in Canada and in Australia too. So it's not just the United States. We have board certified geriatric pharmacists throughout the world.
Oh my gosh, how helpful. Such an asset for people to know where to go. Thank you for sharing that.
Of course.
And the
Of course.
questions, you share about not only how do we go through the MedStrong question list, which I love that you lay out for people to have access to. What are some ideas for caregivers as we're advocating for our loved ones and we're going into different settings like our eye doctor or the dentist? What questions should we be asking? And I know we're trying to cover a lot of information in a short amount of time, so people need to read your book because it's very comprehensive. But we'll kind of do, touch on some things and motivate people to go dig a little bit deeper.
Sure, of course. So I think one of the best things I read throughout this research in regards to answering this question is it was a physician's comment stating, so you've been seeing this patient for some time, and all of a sudden their daughter shows up with them for their appointment. You got to pay attention. Like there's something that's changed. There's something going on. So if that isn't a beacon right there,
Right.
so hopefully you're being noticed. If you are actually bringing your loved one to an appointment, that should be, a first sign, if you will, that something's changed, something's different. So, so it's important. It's important that we take action, that we're there for our loved ones. So going to the dentist, for example, I actually spoke to my dentist and I said, hey, I bet you see a lot of dry mouth. And she goes, yeah, a lot of dry mouth. And I said, I hope your next question is, have you fallen recently? Because like we talked about earlier, that those meds that cause anticholinergic issues, such as dry mouth, also increase the risk of falls. So if someone has really dry mouth, they probably have a lot of meds that have this particular side effect that could eventually lead to increased risk of falls for the patient.
Yeah.
So that's really important. And so what I like to share with people is, it doesn't matter who you're speaking with. Like, oh, is there a lot of dry mouth? Like, you could be asking the dentist that about your loved one. They seem to always want like hard candy. What's going on, kind of thing. That's a sign that somebody has a lot of dry mouth. So instead of adding on more items and products for dry mouth, which there are products out there, think about that med review to help and reduce some of those meds. Same thing with the eye doctor. There's an actual equipment that tells you how dry your dry eyes are. And I go, whoa, let's make certain the meds aren't causing it first. Even with PT and OT, I think about this too. If a physical therapist is saying like, I don't know, we just can't seem to get our balance in straight or not really progressing, why aren't you doing your exercises between our appointments? Are you not motivated? Like, what's holding you back? Different things like that. It could be the medicines. If you just got back from surgery and you're still on the same pain meds and it's been 3 to 4 weeks out and no one stopped the medicines, which I have seen many times, and people don't want to stop because they don't have pain. They don't want the pain. I understand, but the pain's not going to continue on either necessarily.
Right.
So people are still on the same meds and they're going, my loved one is not there. They're not as cognitively present. They just don't seem like themselves or unmotivated. That is meds. And so PT can even be involved, and so asking questions like, are you seeing like they're just not engaged, or, what's the hold up with, why are we still coming? Are they progressing? Those are important questions to ask. They actually a lot of views that you can take on a person's whole self, whole well-being.
Yeah. Great questions. It's that holistic approach. And it's as you were sharing those different scenarios, I was like, it's almost like we're needing to be like a detective, right? Or investigator. and kind of putting the pieces together. And so I think if we can view it that way of being curious, investigating, being creative, right, in our approach, our thoughts about maybe some of those different reasons. How are
I say
you?
to my
Yeah,
students all the time that we're sleuthing.
right.
Like
It's so
as we go
true.
through these med lists, we're being sleuths. So we got to figure this out.
Yeah, yeah. Make
So
it, you know,
yeah,
it's so
so,
interesting. I'm fascinated by it, honestly. What would you say for people that are like, oh, I really am hesitant. I don't want to mess with anything. I've been on these for years. How can you encourage us to relook at that in a little bit of a different way?
I hear that all the time, Nicole. There's a lot of barriers, unfortunately, but I think what's important is you can always pause a med. Doesn't
Mm,
mean you have to stop it, doesn't mean it has to stay off. If somebody needs it, we're not going to say, oh, no, you can't have it. We
mm-hmm.
want folks to be treated. We want people to have the right medicine for them that's going to keep them upright and healthy and within the community, hopefully, but without being over medicated. So that's really important to look at it that way. Like we can actually help somebody feel better. But if somebody's hesitant, we'll just pause. Let's just pause it. Let's just see what happens. I don't really think this is necessary.
Mm-hmm.
The other things that we can do also is it depends upon what the medicine is. If someone has felt something such as anxiety or insomnia or some kind of like discomfort and they're taking something like palpitations or something like that
Mm-hmm.
and they feel it, they're not going to want to necessarily stop that med. But if they're taking iron and it's not really necessary anymore and it's going to alleviate their constipation, darn straight they're going to want to stop that
Yeah.
medicine
Oh.
and they're going to feel better, right?
Mm-hmm.
So some of the things that aren't so like scary,
Right.
if you will, or that they're going to feel might not be the first meds to choose. And you're not going to stop everything all at once. It should be a
Mm-hmm.
methodical um, type thing, unless, there's some reason to stop many. But the other important thing that I think is super important is if you are going to stop something, you should be asking, are there other meds that were added on because of this med, that whole
Mm.
prescribing cascade where you started with this and then had this side effect and then that next thing was
Yeah.
added on, etc.
Yeah.
And that's, for example, iron and then medicines for constipation, for example.
Right.
You can take that, you got to look down that whole cascade as to what's going on. So if you're removing one med, you can probably remove some others, especially if there are prescribing cascades within that
Yeah.
list.
Yeah. Oh my gosh. I just had a personal experience with that where I had one medication and then I realized other things were happening as a result of that. And I went back in and they said, well, we could try these other things to combat the one thing. And then I kind of evaluated it. And, luckily I'm not on anything right now because I was able to kind of look at it. And it was one of those things that, like you said, that moment in time and then
Mm-hmm.
it's not needed. It was a good reminder to me of how quickly that can happen, where all of a sudden, before you know it, you've got, four more meds in your pill box because of one issue. So, yeah, thank you for that. I would love for you to tell us all how we can connect with you. Tell us how you're supporting older adults and families. I know we have your book and we'll share about that on our episode description, but in what other ways and how are you involved in supporting us?
Yeah, for sure. So one is I also have a website, donnabartlett.com, and it has information, it's dedicated to deprescribing. So it has information in there on some of these stories and ideas and various blogs and where you can find me too. My events are also on there, and I have podcasts that are also listed there. I do have a new podcast that I'm co-hosting now. It's called The Med List, and that is available. Kevin Walker and I both. He's also a pharmacist. We take both coastal lines, if you will.
Yeah.
I'm on the east, he's on the
Oh,
west, and we're
perfect.
trying to meet in the
Oh,
middle now.
good.
But anyways, it's all about really thinking as providers. and for the patients and caregivers too. We're trying to bridge that conversation through the podcast. So when we're talking about various topics, we're trying to give both sides of what providers need to be thinking about and what patients need to be thinking about and asking in these conversations. So that's been a really exciting new start for me in that regard. I also do consulting as well, and I speak at many different groups, whether it be senior groups, book clubs. I do continuing education for many types of providers, physical therapists and nurses and doctors and specialists and hospitalists. So many different areas in which I speak. So I'm happy to connect with folks in any one of those ways.
Yeah, thank you. Thank you for your work and wanting to share and educate all of us. I learned so much, not only reading it, but I know in conversation with you. And I'm really hopeful as we move forward, people have support with people like you. So thank you for your work.
Thank you so much, Nicole. It's been wonderful.
Thank you. Thank you for listening today. If you enjoyed our episode, please subscribe and give us 5 stars. In all honesty, we'd love to hear from you. Thank you so much for listening to our episode.